Becoming a doctor requires heavy rote memorization, but clinical reasoning is built differently. It is forged in the quiet, frustrating moments where a student wrestles with conflicting symptoms to build a diagnosis from scratch. Medical educators call this the productive struggle. Over years of this struggle, a psychological shift occurs. The brain moves from slow, analytical reasoning, known as System 2 thinking, where every single data point is painstakingly weighed, to System 1 thinking. This is the rapid, almost instant pattern recognition that allows an experienced attending physician to walk into a room and immediately spot a patient in distress. Forcing that cognitive evolution requires intense, personal guidance. Students need continuous, one-on-one coaching from expert faculty and hours of practice with standardized patient actors to test their instincts in a safe, controlled environment. The math simply does not work for modern cohorts. As class sizes grow, medical schools lack the faculty hours, the physical clinic space, and the budget to provide that level of tailored, individual friction to hundreds of students simultaneously. The very friction required to build a doctor's mind has moved from an educational necessity to a primary administrative strain, a bottleneck that traditional training models can no longer bypass. To navigate these scaling constraints, top institutions are turning to artificial intelligence. This intervention starts long before any student steps foot in a clinic. Using natural language processing, programs like MedTracker and Objective Align GPT ingest entire 4-year medical curricula. They analyze thousands of syllabus pages, slide decks, and lecture notes, mapping them directly to the strict required concepts tested on the USMLE board exams. The AI first summarizes vast source documents, cross-referencing session objectives to hunt for knowledge gaps. Next, it uses that mapped data to automatically generate board-style clinical case questions, calibrated to the exact topics students must master. By semantically linking every lecture to a specific board requirement, administrators can ensure their educational blueprint is mathematically precise, eliminating manual guesswork from curriculum design. Back in the 1980s, educational psychologist Benjamin Bloom identified the 2 sigma problem. He proved that students receiving one-on-one tutoring performed 2 standard deviations better than classroom learners, a massive leap in competence impossible to provide for every student. Now, platforms like Clinical Mind AI use generative AI to apply this concept, providing medical students with dedicated tutors and simulated patients. Instead of static multiple-choice modules, a student uses their natural voice to interview a digital avatar. The AI virtual patient responds in real time, describing symptoms, asking questions, and reacting with dynamic, emotive facial expressions. As soon as the simulated encounter ends, the AI evaluates the student's performance. It points out missed history questions, critiques their diagnostic reasoning, and assesses their bedside manner. This flowchart outlines AI's integration into on-site education, detailing sequential simulated patient encounters. By digitizing these encounters, institutions provide personalized, repeatable clinical training across complex scenarios, completely bypassing the traditional constraints of hiring human actors and faculty time. Solving the administrative problem introduces a psychological risk. By removing the friction of learning, we risk damaging the cognitive development required to practice medicine. Researchers call this phenomenon upskilling inhibition. It occurs when a learner delegates so much cognitive labor to an automated system that they miss the opportunities to develop new skills themselves. Wrestling with complex variables to build a differential diagnosis forces the brain to construct lasting clinical pathways. If an AI steps in and hands a student the correct answer, that cognitive load drops to 0. The learning stops. The danger lies in creating a generation of physicians who act as passive supervisors of algorithms. They might know how to read an AI's output, but they lack the hard-won foundational knowledge required to verify if that output makes sense. If the AI hallucinates, relies on biased data, or simply loses power, a doctor without independent reasoning skills cannot step in to save the patient. A perfectly frictionless education is a psychological trap that can actively prevent a student from becoming a fully capable, independent physician. Medical schools recognize this threat. Instead of banning the technology, they are rewriting the rules of engagement. Institutions are introducing frameworks like the Thinking Habits Matrix. These protocols are designed to force students to critically appraise, challenge, and dissect the answers provided by clinical decision support tools. Students are trained to hunt for algorithmic bias, interrogate the underlying data, and expose AI hallucinations, treating the machine's output as a hypothesis rather than a fact. The goal is to produce an AI-enhanced doctor, a professional who leverages machine processing power while fiercely guarding their own clinical reasoning and human empathy. The ultimate test of 21st century medical education will be measured by how well doctors protect their independent clinical judgment from the